Welcome, everybody. Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for February 20th, 2025. This conference is being recorded. If you're not on our emailing list and want updates, just let us know. We have a YouTube channel. We suggest you go there and see any old conferences that we've had. We're getting close to 100. We'll celebrate with a cake when we get there. As usual, we have nothing to disclose, and the patient confidentiality is being preserved with changing any identifying information. We've got a fun case today. If you saw my tweet, I'm not going to read it out to you, but it was kind of clue or no clue. We'll see about that. This is a case of Dr. Whittier's and Dr. Movis, and she's going to read us the protocol. Bhavna, if you want to take it over.
Okay, can everyone hear me? We were consulted on a 72-year-old woman with past medical history of obesity, hypertension, left foot drop, H. pylori that was treated, DBT on anticoagulation, and gout for evaluation of CKD. Her serum creatinine was 1.3 milligrams per deciliter 6 months ago, but had increased to 2.3 at presentation with hyperkalemia. At that time, her losartan and spironolactone were discontinued. Despite this, the serum creatinine remained above 2.0 milligrams per deciliter. She was also treated for presumed UTI with Augmentin for 5 days. She has had swelling in her lower extremities in the past, but not presently. She noted decreased appetite and weight loss of approximately 70 pounds in the past year. Her ROS was positive for weight loss and urinary urgency. She denied any shortness of breath, lower extremity swelling, dysuria, or hematuria. As mentioned, her past medical history is significant for obesity, hypertension, hyperlipidemia, left foot drop, H. pylori, DVT, and gout. Past surgical history for bilateral hip arthroplasty about 14 years ago and a right shoulder arthroscopy 10 years ago. Her medications currently are amlodipine 10 milligrams, allopurinol 100 milligrams, atorvastatin 40 milligrams, Xarelto 20 milligrams, bupropion daily, cyanocobalamin 100 micrograms, folic acid 1 milligram, and ferrous sulfate 325 milligrams daily. She has no known drug allergies. Her social history, she has current tobacco use since the age of 25, no recreational drug use or alcohol use. Family history with father of unknown cancer, but otherwise no significant family history. On physical exam, she was afebrile, blood pressure 138/76, pulse 66 beats per minute, respiration 16, and was saturating 97% on room air. Her weight is 90 kilograms, height of 5'2" and a BMI of 36.28. On exam, she had no oral lesions. Her lungs were clear to auscultation. Her heart was regular rate and rhythm. She had no lower extremity edema, but had chronic venous stasis changes. And on skin exam, she had no rashes. Lab data and imaging. Her CMP, she has sodium of 138, potassium 5.3, chloride 112, bicarb 18, creatinine 2.4 milligrams per deciliter, BUN of 40, adjusted calcium 10.4, albumin 3.1, AST 24, and ALT 12. On her CBC, white count was 7.60, RBCs 2.95, hemoglobin of 9.2, and MCV of 102, and platelets of 220. Her urinalysis, her specific gravity was 1.019 with a pH of 6.0. She had no proteinuria, hematuria, or pyuria. Her UPC was 95 milligrams per gram, and UAC was 19 milligrams per gram. Her serologic workup, her ANA, Hep B, Hep C, HIV, and ANCA were all negative. Her C3 was 128, C4 is 28, SPEP and UPEP with no paraprotein. Her kappa light chains were 8.84 milligrams per deciliter, and lambda light chains 5.76 milligrams per deciliter, and her kappa lambda ratio was 1.53. Her retroperitoneal ultrasound, kidneys were echogenic. Her right kidney measured 9.2 centimeters, left kidney 9.8 centimeters. She had no solid mass or hydronephrosis. A percutaneous renal biopsy was performed.
Thank you, Bhavna. Any questions for the team?
Yeah,
What
you
about
are
LDH?
I'm sorry.
LDH?
I want to ask about LDH and blood smear, any feature of MAHA.
No, there was a our peripheral smears always report few schistocytes, but the LDH was 220, and I think the reference range is less than 300.
Yeah, I was thinking because the MCV was high, she has anemia. I think of HUS, maybe due to copolamine deficiency, maybe because urinalysis is negative. This is in my mind.
Yeah, that's certainly on the differential. She's actually on cobalamin for her B12 deficiency.
Yes.
Mario, you have a comment?
Yeah, I wanted you, as the expert, because you have published in this area, to explain the disproportion between the UPC and the urine albumin to creatinine ratio in this patient.
I think Mario may be asking Roger, but I'm happy to take it.
Well, no, I think it is me,
I
but
wanted the expert to explain, Roger.
first of all, if those levels are so low, I don't know what to make of them. And when they're that low, all I would say is that there is a little bit of there's a discrepancy, and the fact that it's only maybe 17% of it is albumin, it would imply tubular proteinuria. But when everything's that low, I don't really know what it means in a 72-year-old.
Well, the reason
I'm sorry.
is because of the changes in the basic metabolic panel. Let's see, the appears to have a normal anion gap. I hesitate to call it acidosis because I don't have a pH or a PCO2, but those changes plus the UPC, UAC discrepancy suggest to me a tubular interstitial process.
Fair enough. Yeah, I mean that I have no problem with that. Those levels are so low that, again, in someone that age, I don't know, what it means with some renal insufficiency. Dick, you were going to say something?
Well, I didn't hear an answer to my question about why is she on allopurinol?
You're muted, Bhavna.
Gout.
Gout.
She has gout or she is asymptomatic hyperuricemia?
She has had gout in the past.
Ah, well, that's a very interesting. That's a helpful bit of additional information.
No, it's listed there. I don't want you to think I was trying to trick you, but yes,
It was in the
could be
history.
quite relevant. It could be quite relevant.
Yeah.
And do you want to tell everybody what you're thinking, Dr. Glassick?
Well, one of the
Wait.
Yeah.
wait.
Okay.
No,
We're
'cause
gonna.
I want the poll first.
Yeah.
Okay.
Not to be rude, but I want the poll first. So poll number 1, what do you think this patient has? Autosomal dominant tubular interstitial disease, which would require genetic testing, allergic interstitial nephritis, acute tubular injury without AIN, preglomerular large vessel vasculitis. I think this is in there because something in the history, and or something else.
And a couple things in the chat if people missed it. The MPO and PR3 were negative. Zainab had asked about that given the foot drop, thinking about vasculitis, and then we did not have a recent ESR CRP that was asked by Arun.
Let's let it go a little bit. We can't see your answers, so we see your answers, but we don't know who's voting. So don't be shy. We've never poll shamed anyone in the history of this conference, so
It's pretty good.
all right. We've got 23% says autosomal dominant tubular interstitial disease. We've got 41% AIN, 5% ATN or ATI. One person bought into the preglomerular large vessel vasculitis. That's in there because of the foot drop. And something else is actually number 2. I mean, I won't say anything. I want to hand it over to Dr. Gashti. Casey, take away this easy, straightforward case.
You don't want to let Dr. Glassick
Hey,
tell us what he thought?
Yeah, you can tell us, Dick.
I think lead poisoning has to come in here somewhere. A foot drop, gout, progressive renal failure, and no proteinuria. Anemia, I think lead poisoning would be something else.
I think that's a really good point. I can't tell you how many times I've chased down looking for lead poisoning in someone with CKD, hypertension, gout.
Yeah.
But also, number one gets a stronger vote because as we all know, there are certain forms of ADPD which are associated with hyperuricemia and gout.
Yes, that's why number one is there, exactly.
And lead poisoning usually cause microcytic hypochromic anemia. And
I'm
we
sorry,
saw
Dr.
the
Layden?
MCV is high. Lead poisoning cause microcytic hypochromic anemia. And we found the MCV is high in this patient.
Yeah, I don't know if that could completely rule it out, but that is a good point. It's a microcytic anemia. We don't see a lot of lead these days, the days of battery factories and the days of moonshining are kind of, with where we used to see it in the past is kind of over, but it's a really good point. And, it is a tubular interstitial disease, and this does not appear to be a glomerular process. So, Casey, what do you think, Casey?
Yeah, so I think a lot of the things that I was thinking have been sort of mentioned, but there are a lot of things in her history that would make you think maybe, like the long history of smoking, what makes you think maybe idiopathic or nodular glomerular sclerosis from smoking, lung cancer, membranous, all that stuff. But the UA is totally bland. So this would be a little odd if this was anything that was glomerular in nature, specifically with what we see on the urinalysis and how much protein she has. She has pretty much no albuminuria. So I agree that this is going to be something tubular interstitial. I don't know why her creatinine went from 1.3 to 2.5 within 6 months. That's, I think, what drove people to click on the interstitial nephritis, especially since she got augmentin for an infection. Again, if the UA was from the time of the AKI, it should show us something. I know that the absence of cells in the UA doesn't necessarily rule it out completely, but it makes it less likely to me that this is an acute, at least, interstitial nephritis. Now, chronic, possible. So we may see some cells in interstitium and some diffuse fibrosis out of proportion to glomerular injury. It could also be something that's, some kind of a tubular interstitial deposition, like a tubular interstitial amyloid or something like that. Again, some of those may not present with any glomerular involvement. So LEC2, for example, would be one that would be tubular interstitial with renal insufficiency without necessarily any proteinuria. And that usually is an incidental finding. You don't even really think about it much until you biopsy patients. I don't know what heritage this patient has, 72-year-old woman. Is she Hispanic?
We should have said that, and I'm sorry. She identifies as Black.
Black, okay. I guess APOL1 with hypertension. I mean, that's probably the most common thing, right? I mean, if this patient came to my clinic and she was Black and she had hypertension for many years and she had CKD, I would say this is APOL1, and you would see global glomerular sclerosis with diffuse tubular interstitial fibrosis. So that's my number one, and that's usually a tubular interstitial process, tubular interstitial and glomerulars, and so that would be my something else. I don't have a reason for the ATN. I think the foot drop is 20 years ago. I'm not sure if that's related to this. So I'm going to go with, I hate to say it, the old hypertensive nephrosclerosis or APOL1 nephropathy is my number one. My number two would be a tubular interstitial process. I don't know if necessarily would be autosomal dominant. Everything else people have said about lead, that's very valid. Anything tubular interstitial could be possible. Any acute or chronic interstitial nephritis in the past is valid, except the UAs really takes a lot of the acute stuff out of the picture for me. So I'm going to go with APOL1 nephropathy.
The problem is that there is an acute component. I mean, the creatinine basically doubled in a year. Is that right, Bill?
6 months.
Yeah, 6 months. Yeah, sorry,
Yeah.
And so that's the hard part is anything you've given her, lead, be it you know, ApoL1, it just wouldn't, you wouldn't have that kind of
Yeah, I mean,
deterioration unless you've got something on top of something.
right. I mean, the trouble is we see that this a lot in clinic. You know, somebody has been running creatinine of 1.5, they come in as 2.5, you stop their losartan, you stop their diuretic, they had the flu, you bring them back 2 months later, the creatinine is back down to 1.7. So, you know, it could be an ATN from some unknown hemodynamic insult on the kidney, which
Yeah.
we're not going to guess unless, you know, like, and you wouldn't biopsy either. You just follow it and see what happens. But, you know, we have a biopsy here, so we'll know.
And I
Yeah,
would say
Hey,
that,
Casey,
yeah,
Casey,
go ahead.
Yeah.
in the ASK trial, AASK trial, none of the Black patients who had a UPCR less than 0.22 progressed to CKD. So ApoL1 nephropathy without proteinuria in a hypertensive Black is pretty unlikely. I think the proteinuria here is just too minimal to introduce ApoL1 risk alleles. Now, I may be proven wrong, but the ASK trial would definitely point away from ApoL1 in this patient.
That's fair.
We did hold her, I think we did hold her diuretics and things like that. And when it came back still elevated, in fact, I think it went even further up to 2.4. And so that was the other reason to sort of urgently bring her in for biopsy. In fact, when I saw her, this is what I was thinking was tubular interstitial process and maybe just send off genetic analysis first, as I know Zainab had said in the chat. But because she was going so fast, I thought, I don't have 6 weeks to wait for that to come back. I've got to get a biopsy done.
This is really a crazy story. I mean, to have this much going on with really such a benign urine, and I'm sure it's been repeated, it's really kind of bizarre.
Yeah, we did repeat the urine.
And, you know, and biopsying somebody who's with nothing in their urine is kind of unusual.
Yeah, I mean, this was definitely one of those rare unexplained AKIs where I was maybe, you know, looking for some interstitial nephritis that I could treat for something acute, even not knowing what the cause would be.
Dr. Raj Sakaran, what do you think's going on?
Yeah, hey Roger, thanks for having me. It's just a very interesting presentation. I was just focusing more on the CMP and the urinalysis. If you look at the CMP, the patient has, you know, the potassium is a little elevated, hyperkalemic, hyperchloremic, non-anion gap metabolic acidosis with the urine pH of 6. So there is acidification defect, which points towards tubular interstitial process. Plus, this patient is not on a renin-angiotensin-aldosterone system inhibitor, yet seems to have what is hyporeninemic hypoaldosteronism. So, you know, I am thinking that there is some defect in the thick ascending limb, and putting it all together would be autosomal dominant tubular interstitial kidney disease, probably a REN mutation, but I could be wrong.
Yeah, I kind of like, you know, this whole gout renal failure, unknown renal failure association. I still think if you had a creatinine of 2 from chronic tubular interstitial disease, you have some proteinuria, but there's no, we have to throw out some information no matter what. I don't think there's any way we're going to come up with something that really fits this, the clinical presentation. So, Dr. Zainab, what do you think's going on?
Hi everyone, good to see you all again. Yeah,
We miss
very
you. You
interesting
have to join more
case.
often.
I know, I'll try my best. I'm actually working from home today, so very convenient. But yeah, I think I agree with everyone. I think it's more tubular interstitial. What's interesting though is that she also has this weight loss history. She's elderly, so always have to think about malignancy. But what's interesting, she's not like proteinuric, which would make you think of membranous. So this tubular interstitial pattern, I mean, you do see it with IgG4 disease, but again, in her case, no history of abdominal pain, no pancreatitis, just something in the tubules. But I just, you know, I feel like the biopsy needed to know more, honestly. But yeah, nothing more to add.
I like the IgG4 thought because A, it hasn't been brought up. B, we never think of it because, you know, well, we don't always think of it right away. And C, I mean, if it was an obstruction, she could have an obstruction without a, you know, not obstructed dilatation if it was retroperitoneal fibrosis. So I think that's worth, you know, just commenting on. I like that.
Did she have imaging done, like a CT to look for that? like for any
No,
retroperitoneal
just
type?
the ultrasound.
Oh, I see.
You know, it's funny how many things come out during the conference that are really good ideas that, oh yeah, we should have thought of that. Comes out with it comes out with the polls too, as
It's funny because
Dr. Glassick brought up the lead.
And I think I didn't really think of lead, and that's such a good point. I did consider IgG4, and I thought I sent off the level, but it's not here, so I don't know what happened to it.
I
Yeah,
think we should always have a something else in all of our polls.
Yeah. With this smart of an audience, it's going to be filled.
yeah. All right, let's look at the path, eh? Pull up the wheel. All right, wheel. Oh, why not?
Casey.
Dr. Gashty.
Yes.
Spotlight. I'm gonna share here. Give me a second. And I'm gonna give you control. All right, go ahead and click. Yep, you're controlling that.
Hear me okay, Roger?
Yeah.
All right, our first slide here is a trichrome stain. We have two cores, three pieces. There is some on the top core, there is, I would say about 50%.
You're getting into the medulla over there where they,
Here?
yeah,
Okay.
that's into medulla. Yeah.
Okay. So if you take, there are definitely some obsolescent glomeruli. I can see one that's over here. I see a bunch of this is sort of the capsule, right?
No, those are tubular casts. The little
The
thyroidization right there.
thyroidization. Okay, so
Yeah.
cons. Yeah, here's another dilated tubule. Pretty significant, I think, arteriosclerosis here.
Yes. Yep.
But the glomeruli, so I see a few here. And I don't see anything from this power at least, but I guess, if I had to pull all of this together, ignoring this top piece, I would say, I don't know, 25 to 30%.
Good. Yeah, sounds good.
Okay.
What about the ectatic tubules that can be appreciated at this power?
They're definitely very dilated. This tubule is twice the size of a glomerulus, and some of these other ones are very much dilated. So, I would have expect to see like wide, like waxy casts, like on her urinalysis. And this, I suppose, I don't know if this is just attributed to her having chronic kidney disease or something along the lines of like, HIV or a hypokalemic nephropathy, these things that affect the tubules quite a bit. I don't know the mechanism, but they're definitely dilated. I don't know I don't know the etiology of why they're dilated, but they definitely look very dilated. Aneurysmal, almost. Here's the glomerulus. This is on H&E. This is kind of hanging off the edge. But at this power, there is some very maybe mild mesangial hypercellularity. The capillary loops are open. I don't see any segmental scars. I don't see any proliferation. Obviously no
Yeah.
crescent.
What do you think about the mesangial matrix, Casey?
I think it's mildly increased.
Yes.
There are two areas, one here, even maybe this area.
And down at 5 o'clock as well.
extensions.
Yeah. 5 o'clock as well. Down in the bottom right.
Oh, yeah, here.
Yeah. Yep. Yeah, kind of throughout entire glomerulus. Yeah.
Okay. Even for, I remember back when we were reading these with Dr. Lewis, he would say a 20-year-old, you shouldn't see any mesangium, but as you get older, you get some mesangial expansion as part of just the natural aging kidney. Is that statement crazy or is that valid?
No, but it's significant in this case. That's why I'm pointing it out.
Got it. Okay. All right. So you're giving me a clue that there's a glomerular process.
Yeah.
All right, so here are two glomeruli. Now I'm definitely seeing what you're saying. There's definitely a lot of mesangial expansion throughout. I mean, this is probably the vascular pole here. So even if you go away from it, you can see quite a bit of mesangial expansion in both of these glomeruli. It looks
Yeah.
pretty abnormal. The tubules, so we have a proximal, these are proximal tubules. Here's a distal tubule. They look okay to me. There's this one is there's some hydropic degeneration of that proximal tubule. So there's some tubular injury, maybe up here as well. There's some sloughing of the brush border, but I think the focus is this glomerulus with mesangial expansion, a little bit of periglomerular fibrosis.
Okay.
Here's a PAS stain. So this mesangium is staining pretty heavily for, pretty strongly for PAS. So this goes against amyloid. But albeit this is quite a bit of mesangial expansion.
Hey, David,
Yeah. Yeah.
when is it, that's, I mean, it is diffuse, but when does that much really more qualify as a segmental scar as opposed to just,
They're cells though. They're nuclei.
Yeah, and I still see open capillary loops
Yeah.
through that segment.
all right.
Yeah.
Yeah. I would have said, I mean, there are open capillary lumina here and inside, and there are a lot of nuclei. So I would call this as expansion as opposed to a scar.
Yeah. Yeah, I agree with Casey.
Is it compared to Bowman's capsule there, is it weekly PS positive, Casey, or
No,
is it
it looks the same to me. I
same?
mean,
Okay.
this area probably folded, maybe looks a little stronger, but this is not what I would expect with amyloid.
Okay.
If you look at the tubular basement membranes, they're about the same.
Yeah, it's like this one's, but yeah, here and here, same. Here's the Jones stain. We're looking at the peripheral capillary loops. We're looking for any spikes, holes, breaks. I don't really, they seem thickened, but I don't really see any spikes or holes.
Yeah.
Yeah. Okay. Congo red looks negative.
Yeah. It's a negative for amyloid.
Okay. This is an artery. And this looks pretty significantly sclerotic.
Yeah, more than 50% narrowed. Yeah, severe arterial sclerosis.
Okay. Here's is this a capillary here?
That looks like a Tam
Yeah, tubule.
Harskel tubular cast.
Tubule, okay, because I didn't know. I was like, is this a TMA? Okay.
Yeah.
All right, so capillary, I'm sorry, the tubule. All right. So now we have IgG, which is positive in the mesangial areas, but not in the peripheral capillary loop. Yeah, it's pretty positive mesangial. Kappa and lambda are both positive, so non-restrictive. And again, they're both in the mesangial area. A little bit more lambda on the kappa, but I think maybe, I don't know if that's exposure, but either way, it's not restrictive.
Yeah.
C3 is also positive. This part is definitely mesangial. I can't tell if this is capillary wall, or I can't really tell what's in the background, but it's definitely mesangial.
Yeah.
What about the IgA?
Negative.
Thank you.
So it's IgG, C3, kappa lambda.
Yeah.
Got it. All right, here's an EM. Here's the basement membrane. Here's the capillary space. This is the blood space. Here's the urinary space. The podocytes here, they look pretty damaged. I feel like they're kind of lifted off. So I don't know, but I don't really see foot processes. Maybe we'll see a higher power of this, but I think the big feature is this mesangial electron dense deposits, which I hope we get a higher power of this. There's definitely expansion with something in here, so we'll see what that something is. It's not amyloid. It's got to be fibrils or tubules. Oh, they're fibrils. And they're randomly They're not organized, so they're random fibrils. Do we have measurements?
20 nanometers.
20?
Yeah.
Okay. And I assume this is in the mesangial area.
Yeah.
Okay. And they're fibrils, not tubules, because I don't
Right.
see, yeah, they're,
Yep.
so it's suggestive of maybe fibrillary GN. Oh, and their DNA JB9 is positive. Nice. So fibrillary glomerulonephritis with a positive DNA JB9. I'm shocked. This is in the glomerulus. So this is a glomerular disease with no proteinuria.
Yeah, I think we're all kind of speechless. We have a wow and a shocking, both in the from two of our expert panelists, and I think that's exactly how we felt when we got it. I mean, that was not on anybody's radar, as it should have been. It should not have been on anybody's radar. If it is, I would say you're cheating. But what a surprise! I think we have another poll.
I immediately rechecked the urinalysis, and
Yeah.
it still had no protein, and the urine PC was still like nothing, and AC. Just she has something in her bladder that's eating up protein, I think. Not much of another explanation.
So we'll get into the case a little bit more, but I want to see what people would do next based on this. Would you do some Dr. Glassick? I want to. Hey, Pravir.
Yes.
Can you? Dr. Glassick is just rejoining us. Can you show him that last picture?
Yeah. Give me 1 second here.
Once he's on, is he back on?
Okay, this one and let's see.
I don't see him. Do you?
There
Okay.
he is. And this.
So, Dick, welcome back. Here's the big surprise. Normally I wouldn't pull this back, but I think you need to see what this patient has.
Fibrillary GN.
And it was glomerular,
Very glomerular.
not.
I
not
think
really.
he's muted.
It's all right. As long as for him to see the rest of the discussion, I think it's important to see this, see the money shot. So our poll is coming through. Pretty equal spattering of answers. We could probably stop it there.
That's a retire from practice. That's number 4.
So genetic testing, malignancy workup, bone marrow, or retire from practice. I threw retire from practice in because I think it's, oh, we got to take a screenshot of that because that's the number 1 vote. I got it. That is, and what a wonderful little GIF you put in there, because that's exactly, I think, how we all feel after seeing this case and having absolutely no clue that would be, and to come up with this. I want to hand it back to Casey. You could talk a little bit more about this.
Well, fibrillary, this really adds to the spectrum of clinical presentation of fibrillary GN. I don't think I've ever seen a case like this before, but now I have to admit they must exist. Genetic testing won't tell you anything. A malignancy workup with a 70-pound weight loss might be appropriate. There are a few cases of fibrillary that have been associated with malignancy. I don't think a bone marrow biopsy is going to help you at all, unless you consider that a part of a malignancy workup. And I think probably in a 70-year-old person with a 70-pound weight loss with a new diagnosis of fibrillary, I would look for occult malignancy. Maybe lung, particularly because of their smoking history.
Any other strong thoughts?
I think whoever posted in the chat about hepatitis C is another strong consideration.
Yeah, we've seen that before. That was negative in the protocol.
Yeah.
But that is one of the stronger associations, absolutely. Um, well, let me hand it back to Bill then. I think, Bill, you could tell us a little bit more about the case.
Yeah,
Well,
I mean, I was shocked. It didn't make any sense. We were thinking all tubular interstitial disease, and I was as shocked as everybody here. But this was, yeah, a case of DNA JB9, fibrillary glomerular deposition disease. So I'll talk just briefly about that. Let's see. Can I control it?
You're
Premier?
controlling it. Go ahead.
Okay,
Oh, there you go.
deal. There we go. So for follow-up, this was a pretty recent case. And I had a CT chest, abdomen, and pelvis has been negative for malignancy as far as any kind of masses or lymphadenopathy. She has had a mammogram that was negative, and she had a colonoscopy 1 year ago that was negative. Her HCV antibody for hepatitis C was tested 3 times actually, and I just got an HCV RNA as well, which was negative. And her autoimmune profile is also negative. And we already knew from the protocol that she had a negative serum and urinary fixation, and her serum free light chain was just consistent with CKD. And she also didn't have any kappa or lambda light chain restrictions, so there wasn't really much to think about as far as a monoclonal process. But so yeah, that's kind of where I am in the workup of her, and that's the follow-up I have. Her creatinine.
Bill, do we have a good sense of how you lose 70 pounds in a year?
No, I mean, after I saw the biopsy, then I was convinced it was definitely going to be cancer. You know, and I also thought smoker, it's probably going to be lung cancer, because she'd already had that, you know, colonoscopy. Her CT abdomen and pelvis had been done 6 months ago, but she hadn't had a CT chest. So then I got a CT chest and it was negative. So, you know, no, I don't really know how she's lost weight. She has socially had some social issues that, you know, we don't necessarily need to go into, and maybe some depression, and that might have been part of her weight loss. But I mean, it was a significant amount of weight loss, and it really was unintended. She wasn't trying to diet, and she hadn't been sneaking a GLP-1 or anything like that. So, you know, that's where we were. And so I'll talk a little bit about fibrillary GN. It was, you know, first described in 1977, and initially it was lumped in with ITG, immunotactoid. And Ed Lewis had 2 things that he always said to me that I thought were very funny, was that he wanted 2 different words put into Webster's dictionary and to be attributed to him. And one of them was immunotactoid, and the other one was podocytopathy. The immunotactoid, he had named it because in 1980, and I think it was in the Archives of Pathology or one of those journals, Mel and Ed had published a case of a patient who had what they termed ITG, and the reason he called it that was because the fibrils, or what they thought were fibrils, on the biopsy had looked more like tactoids from sickle cell disease, as you can see in the upper right-hand corner there. And they thought that perhaps they were part of the spectrum of non-amyloid type of fibrillary GN. And because the immunofluorescence was positive, he named it immunotactoid.
You know, Bill, I think that when you look at those sickle deposits on EM, they actually look, it was more than the light microscopy appearance, that even on EM they had that kind of microtubular appearance.
Yeah, that's right. And I'm not quite sure how well you can see it here, but it almost looks like little and again, this is ITG. I'm not talking about DNA JB9 right now. I'm still talking about the beginnings of describing fibrils that were not related to amyloid, but you can see it here. They really look sort of more like tactoids. And so that was the name that it was given, and it kind of stuck, which I thought was a nice little bit of history. And for the longest time, there was this whole debate that's not really that important, but the tactoids and the fibrils that were non-amyloid were thought by Lewis and Schwartz and Corbett to be sort of the same process, and perhaps there was just different chemistry makeup which made them look different. And they kind of lumped them all in the same category, you know, saying that not all of them, or that some of them can actually be from a primary kidney disease as opposed to a secondary disease. And since now in the world of DNA JB9, we know that they're actually quite separate, but that was sort of the beginning of it. And another thing that I'd always said about it, that it was sort of like a bowl of pasta. You know, you can have some, you know, pasta that looks like rigatoni, you can have some that looks like linguine, but they're all really still just pasta. And I think that's borne out to be something different, but keeping something simple like that is always sticks for me at least. So, you know, Steve had published this article too, and Jason, about ITG, and really talking about there's amyloid deposits or the fibrils, and then they're non-amyloid, and this still is relatively true. And now we've got the non-immunoglobulin derived ones or the immunoglobulin derived ones, which can be fibrillary or immunotactoid, and there's some other ones here into also. So we'll get a little bit more into that. And so we still to this day split it up into Congo red versus not. And if it is in the negative Congo red, if the immunofluorescence is positive, we think about these three categories: immunotactoid, as I just went into, and fibrillary GN. And if they're not immune globulin, then you're thinking about one of these, like fibronectin, which I still haven't seen a case of, but I know they're out there, or even diabetic fibrillary or fibrillosis. So in 1996, Helmut Reinke published their experience with fibrillary GN, and this was sort of the typical one. Now I'm kind of switching away from ITG and going more into the fibrillary age, and notice quickly that 100% of the patients presented with proteinuria. So when Dick said that this is added to the diversity of how a patient can present, he was absolutely right. Most of the time they're nephrotic. I think the average proteinuria is somewhere between 4 to 6 grams at presentation. They have a significant amount of CKD, and this we didn't touch on as much, but this case also, if we want to go back and look at the immunofluorescence, did have these sort of smudgy appearing deposits. They're sort of a little blurred, and they're called smudgy. And then you can have these 20 nanometer non-organized fibrils, as we saw in our case. And as was mentioned, Hep C is a big one, malignancy is a big one, and some autoimmune diseases as well. So then DNA-JB9 came out, which is basically a protein. It's a heat shock protein, and it was found on mass spec and on proteomics and so on to be very specific for fibrillary GN. And this was one of the first reports. It was reported in 2017, and then several other reports came out in 2018. And what the heck is DNA-JB9? You know, it's a member of these heat shock proteins, but what the heck are heat shock proteins? They're basically there in the endoplasmic reticulum, and they respond and they're upregulated when you're, you know, stressed. So it's viral stress or heat stress, things like that can bring these out. Now, how they then attract immunoglobulins to be positive on, you know, the immunofluorescence is still a matter of either controversy or really just call it unknown. The two going theories are, one, that they act as an antigen, and that the antibodies, of course, are coming to them, and that's how they're getting there. And another one is that they might actually trap sort of misfolded immunoglobulins, and that might be that they're almost like a magnet for misfolded or degrading immunoglobulins. The problem with both of those theories is that there are some cases of DNA-JB9 positive glomerular disease that's immunoglobulin negative.
Yes.
So that can't quite be the entire story of DNA-JB9 fibrillary glomerular sclerosis. So most of them, though, are Congo red negative, okay? And most of them in the DNA-JB9 standing is not found in amyloid, in non-fibrillary, and myeloma, and a lot of these other ones. And so DNA-JB9 is very specific and sensitive for fibrillary GN. And they're also not found in ITG. But again, there's some unusual variants. Some are a little congophilic. Some can be monotypic. Some do not have immunoglobulins, like I just mentioned. Some can be crescentic. We actually had a case of crescentic, I think, a couple years ago that Dr. Baxi presented. And lastly, I'm adding mine to it. Some can be non-proteinuric. Although I still don't believe that. I just can't wrap my head. I just still can't wrap my head around that.
Yeah.
So treatment, the bottom line for treatment is we have no idea. It's unknown. Even Rituximab is going to say that it's unknown. Okay. Most of the data, though, is towards Rituxan, and it is with variable, if not poor, success rates. Time to end-stage renal disease is, on an average, depending on your baseline serum creatinine, around 2 years. But Rituxan's been looked at in several small studies, and this was another pilot trial where they used Rituxan in patients who had fibrillary GN. Again, not a lot of patients. And in general, their proteinuria went from about 4 grams to 1. That wasn't statistically significant. None had a complete remission, and most of them still went on to end-stage renal disease. And so we just don't know what a good, besides, you know, using ACEs and ARBs and possibly Flozins and so on and so forth, what is a good treatment. Even the ones that have cancer or the ones that have hepatitis C have not had a universal response to treatment of the underlying disorder. So right now, we really don't have a great grasp on how to treat these patients with this disease.
Does anybody have any personal experience treating this? I know probably it's all anecdotal, but I'd like to hear what anybody says.
Yeah, Roger, I've treated a few patients, I think 3, and one out of the 3 had a decline in proteinuria. None had a complete remission. It was very delayed. It didn't occur in the first 6 months, and it was only after repeated doses. So inconclusive. Who knows? I will add that there is a trial in progress called the FACT trial of ACTH, Acthar gel, from the group in Nashville, or in Atlanta, rather, the NephroNet trial group. And I know the results, but I'm not going to say what they are. But there is a publication in process to describe the use of Acthar. Interesting.
I mean, that'd be a tough study to do since it's a pretty rare disease.
Yeah.
I pulled up an article on recurrence in transplantation, and this is probably more authors than patients in the study, but it's predominantly out of Mayo. They had 14 patients, and only 3 of them recurred, which is interesting. You'd think that there would be a little more than that, but they only had a median follow-up of about 4.4 years. What was also interesting, 3 of the 3 that had a monoclonal protein associated with it, the 3 that had a monoclonal protein, none of them recurred. Now you'd think I don't know, I would tend to think that would have a higher recurrence rate, but you know, maybe not. Maybe the monoclonal protein is, you know, not related too. Maybe it's just a lot of people have monoclonal proteins as they get older. So, Bill, what was the median age of FibGN? Do we have that?
See if I can go back here.
While you have this slide up, Bill, can I comment about it?
Said middle age 41 to 80. This one or the next one?
The serum. Look at the specificity. The specificity of an elevated DNA JB9 is very high. The sensitivity is low. There is no commercial assay for DNA JB9 that is approved by the FDA. But, you know, I wonder whether a positive, that is a DNA JB9 above 1 nanomole per liter would be a useful test to screen. It has low sensitivity, so it's not going to be all that helpful if it's negative. But if it's positive, it means something. And of course, this is a first generation assay. Maybe mass spec or some more sensitive assay would even be better. So I think there's still some room for serum testing in suspecting DNA JB9, but it certainly is far from where it should be.
And it'd also be fun to see if you can change that level if it correlates with renal disease. It might take a year or more, like PLA2R, but I don't know that anybody does this outside of Mayo or somebody else. I don't know. Where was this from? This was Mayo. Okay, no, Nasser. Yeah, at least he's the lead author, and Fernando's there.
Yeah.
Mario.
Yeah, along those lines, I had an extensive conversation a month back with Dr. Alexander, who is the senior author in this publication. And as Dick pointed out, they are actually working on trying to ascertain what's the best way to establish whether or not the blood levels of DNA JB9 do correlate with both diagnosis and disease activity. And the other thing is, Nelson Long has emphasized in the past that monotypic variants of fibrillary IgN are not common. And I was surprised to see the percentage. I think it's on this slide. Actually, there is no percentage. Have you come across that data, Bill, on how common the monotypic forms of fibrillary GN are?
Let me take a look. I actually know that
1%.
yeah, that's right. I think I heard Dick say that. I was going to say less than 5%, but I think he said 1%.
1%.
So it's not common.
Yeah.
And thus, it's not recommended for them to get a bone marrow biopsy. But you know, I'm sure if there was light chain restriction, then I would be thinking differently.
Mario, someone comes to you with this disease, would you suggest they not get transplanted, assuming that, they're otherwise healthy? What would be your approach?
Send them to Mayo. I wouldn't. I don't have the necessary expertise to handle it.
And since we were discussing the diagnostic value of the testing, I also want to comment that the diagnostic value of the stain can be important as well, because it could be quite helpful to make a diagnosis in places that don't have electron microscopy.
Right.
Most of us all do, of course, around here at our renal biopsy conference, but you can get this immunohistologic stain and diagnose it without even getting to the fibril level that you would see on EM.
Well,
For the pasta enthusiasts, I love your analogy to pasta, because ITG is like bucatini and fibrillary is like spaghetti.
There you go.
So it's a beautiful analogy. I'm going to use it next time I give a talk.
You can quote me, but I was quoting Ed Lewis, and that man
I love it. Love it.
had some great things that he said in his day.
Yeah.
Dr. Zainab, would you like to elaborate? You put something in the text?
Yeah, I was actually reading like a PubMed article. I'm just going to post it here, but it did mention that immunohistochemistry staining is very sensitive and specific. So it is dependable if you don't have any other resources to test for it.
Pravir, can you put back on the smudgy IF? And this is really, yeah, this is for our fellows. If you see this, it should just scream to you, fibrillary GN. If you see this on your boards, it's. I suppose IgA could look like that as a predominantly mesangial disease, but I don't think it has that smudgy appearance. I wouldn't call it this is not so smudgy there, but I wouldn't call it pathognomonic. But
yeah, it almost feels like you
picture.
adjust your microscope, because it's kind of blurry at the edges, and you think you're not getting that fine tuning, but it's just how it is. It's smudgy.
Yeah, that's a good way to say it. Yeah, you kind of go up and down on it. It never gets that fine. Yeah.
Roger, that's a very good point, because in IgA nephropathy, you usually see discrete granules. If you don't see discrete granules, and it's a mesangial pattern of IgG and IgA, I think fibrillary should be in your differential diagnosis. And of course, if you don't have EM, as Bill has pointed out, do a DNA JB9 and you'll get the answer.
The other thing that is common in this disease, besides the fact that it affects females more than males, is high blood pressure. Yet this woman was not hypertensive, was she?
She was.
Oh, was she? Okay.
Yeah. Yeah.
Yeah, and it's always important to know your fibrils and know their sizes, because that's another, real common board distinction. And
yes, right.
This is a little bit of overlap, but it's not the 10 that would be amyloid, although, the Congo red was negative.
Yeah.
And as
Well, I don't know, I'm not gonna retire from nephrology, but this threw me for about as much of a loop as any case. And, Dr. Glassick, who's seen a little bit of about as much as everything as anybody, wants to put this now on the list of presentations for fibrillary GN. I don't know if you can, something that's this crazy is anything beyond a case report, but maybe it should be a case report. It's so wild, but you have to be careful that you don't get overwhelmed by the crazy ones.
Well, how many reports in the literature prior to DNA JB9 showed mesangial IgG deposits and a very limited degree of proteinuria. I think we have to open up our minds here and say, listen, if we're doing DNA JB9 on every biopsy, we're going to pick up a lot of patients with outside of this spectrum that he describes, 100% proteinuria and mainly nephrotic.
Yeah, that's a good point. I mean, you're implying with it, we've missed them probably because we didn't think to look for it, and that's always a possibility. I mean,
I
it's
just
also
want
just
to underscore the value of the kidney biopsy in the diagnosis of renal diseases.
Mario, we would never end a conference without you stressing the importance of a renal biopsy. And with that incredible wisdom, I think we'll move on.
And kudos to the primary care doctor who's noticed something was a little funny, and I had to get her in really almost right away because it was too funny to fit anything, and I certainly wasn't expecting this, but I knew it was going to be something odd.
Dr. Reen, last comment.
Okay, I think there is a case report with interstitial nephritis and DGN February nephro. But what surprised me that it doesn't show any interstitial disease, mostly grammar. But there is a case report. I'll find out. I'll send it to you guys.
I mean, if I had to guess, this had to be interstitial, something odd, granulomatous nephritis, or something just out there, or IgG4. It's just a crazy story. But as Mario said, if you don't know, you got to look, and we made a great diagnosis. Thank you everybody for coming, and we will probably be off next week, but keep your emails open, and we'll let you know when we're on next. And until then, everybody stay safe.